evening, everyone, and a very warm welcome to the 6th round of the Grand Rounds conducted by Uveitis Society of India. And it has been really very encouraging to see the high amount of attendance that we are getting from world over for these Grand Rounds. And I'm sure that it itself is an indirect assumption that we can make that these Grand Rounds are being extremely well taken, and the discussions are found useful by many of the uveitis experts all over the world. So today we have a whole panel of experts in uveitis, and I would just request Hallmark to show up the slides. So before we go to the panelists, I'd like to congratulate the winners of the case presentations of the 5th Grand Rounds, which were conducted last month. And we have Dr. Ayushi Sinha from All India Institute of Medical Sciences. She has won for the best case presentation on positional amaurosis fugax and blue sclera, a diagnostic dilemma. And we also have Dr. Mosmi Banerjee. She presented a rare case of atypical peripheral retinitis, clues to diagnosis. So very hearty congratulations to both of you, and you are going to be getting a free registration for the forthcoming annual USI conference, which is going to be held at Hyderabad from 14th to 16th of October this year. Moving on to the introduction of the panelists for today. We have Dr. John, who is an associate professor at the University of California, San Francisco, USA. A very warm welcome to you, Dr. John. We have Dr. Ahmed Salim. He's an associate professor at Harvey and Bernice Jones Eye Institute at the University of Arkansas for Medical Sciences, again from United States of America. We have Professor Peter McCluskey, Professor and Chair of Ophthalmology, Director, Safe Sight Institute, the University of Sydney, Australia. We have Dr. Brian Toy, Assistant Professor of Clinical Ophthalmology, Director of Clinical Informatics and Information Technology, Service Chief of the Uveitis and Ocular Inflammation Service from Roski Eye Institute, Los Angeles, USA. And we have our very own Dr. Vishali Gupta, Professor and Head of the Uveitis and Retina Department from Postgraduate Institute of Medical Sciences and Research, Chandigarh, and she is also the current President of Uveitis Society of India. I hope that Dr. Sunil Srivastav also joins in shortly. He is a vitreoretina physician at Cleveland Clinic, Cole Eye Institute, United States. So thank you for joining in today, and a very warm welcome to all of you. We also, what is the plan for the Uveitis Grand Round for today is that we are going to be having a clinical talk by Dr. Soumya Basu, who is the head of Uveitis Services at LV Prasad Eye Institute, Hyderabad. And today he would be speaking to us on connecting the seen and unseen clinical immunological correlation in uveitis. And this talk subsequently is going to be followed by some very interesting case presentations. So over to you, Dr. Basu.
Thank you, Dr. Manisha and Dr. Vishali for this talk, and also for including LVPI in this wonderful program. I'll share my slides. I hope I'm well audible and the slide is visible now.
Yes, you're good to go.
Yeah.
Thank you. So we'll talk about the clinico-immunological correlations in uveitis and how we connect what we see in the fundus and what is not seen, what works behind the scenes. The stuff that we see, and as ophthalmologists, we are very lucky that we get to see all the disease processes, be it in the anterior segment or in the posterior segment, directly starting off and then increasing and then resolving over time. And these are the different clinical phenotypes. For example, here we see the perivascular infiltrates, the macular edema. In another patient, we might see a choroiditis lesion, another one we might see retinitis lesion. So all of these are directly visible to us. These are the basis for all the morphological diagnosis and for the diagnostic and therapeutic decision making that goes along with it. But what works behind the scene are the immune cells, and these immune cells are the different phenotypes, the neutrophils, the lymphocytes, and the macrophages that are responsible for these disease processes. These also secrete different types of cytokines and have other kinds of functional profiles, and they interact amongst themselves with the stromal cells and with the microbial pathogens that might be involved in the disease process. Also, very importantly, this entire immune response evolves over time from the beginning of the disease towards the end. Now, this is very important because this is what is responsible for the disease progression and finally the resolution, and how the disease responds to the treatment that we administer to the patient. How do we study these immune responses? The most common way is to look at different kinds of animal models, and we have some fantastic models, especially in mice. We can also look at human samples in different types of in vitro studies, and I'm going to talk about some of them now. Now, the function of these different kinds of immune cells can be studied by looking at the protein, which can be studied by ELISA or by mass spectrometry, which is kind of a bulk analysis of the kind of protein that is being produced, or on a single cell basis, as we do in a technique called as flow cytometry, which I'll describe very shortly. The other way is to look at the gene expression, that is the kind of RNA that is being produced in a given cell or in bulk when a particular disease process is going on. So these are overall, I think, we as clinicians will understand at least this much part of the study of these immune responses. Now, obviously, we cannot talk of the entire spectrum of ocular immunology or the immune responses in uveitis within this 10-minute talk. So I'm going to focus on what we have done with the pathogenesis of intraocular tuberculosis. And in particular, I'm going to talk about the two different types of antigen-specific responses that we have demonstrated in ocular tuberculosis. One are the TB antigen-specific responses, while the second one are the autoantigen or retinal antigen-specific cytokine responses from the cells that we collect from cases that we call as ocular tuberculosis. Now, I'm going to describe how the TB antigen-specific responses would differ between what can be called as quote-unquote true ocular TB and the other uveitis entities that also have a positive MON2 or IGRA test. And I'm also going to talk about how the autoimmune responses would differ between different types of uveitis. I hope all of you are with me till this time. So why do we want to look at autoimmunity in a patient with ocular tuberculosis? I think we are all aware that it's very difficult to get not only microbiological, but also molecular evidence of tuberculosis from the ocular fluid samples that we have with us. But this does not allow us to connect the TB infection to the intraocular inflammation that we are seeing inside the eye. So we formed a hypothesis that if ocular TB is truly an infection-driven disease, then the intraocular T cells that we collect from these patients should be responsive to the TB antigens and not to the retinal autoantigens. What did we do? We collected the vitreous samples from patients with ocular TB, of course, with prior IRB approval and written and informed consents. We isolated the immune cells from these vitreous samples, and these were a collection of different types of immune cells. We activated the entire bunch of cells. We could not sort them into different types because the numbers that we get are very small. So we activated all of them with either the TB antigen, which in our case was the same ESAT6 antigen that is used in the quantiferon test, or retinal antigen, which in the early studies, we used the retinal crude extract. And then we looked at the cytokine response from these cells in response to either antigen. Now, what is this technique called flow cytometry that allows us to measure the cytokine responses from individual cells? This is like looking at a bunch of soldiers who are carrying different types of weapons or sometimes no weapons at all. So as you can see, we have a dot plot here, which has 4 quadrants, and the lower left quadrant is the one that has the maximum number of dots. These individual dots represent different cells that we have in the sample. Now, you can see that the lower left corner has most dots, and this one and these ones are the cells that are not producing any of the 2 cytokines, either on the y-axis or on the x-axis, when they are being activated with a particular antigen. The ones on the lower left, lower right corner are the ones that are producing interferon gamma in this case, and the ones on the upper left are producing IL-17. And the ones that are in this quadrant, which is the top right, are producing both IL-17 and interferon gamma. I think this is a very simple concept to understand which category do individual cells in the sample fall in terms of their cytokine production, just like identifying different soldiers with different kinds of weapons. So what did we find? We found that the cytokine response to that there was a cytokine response from these samples to both the TB and the retinal antigens. The retinal antigen specific immune cells were more pro-inflammatory. They were producing more cytokines, and they were also resistant to cell death. Now, this was the broad finding that we published about 4 or 5 years ago in 2017. What have we done after that? So the next thing we wanted to see, how would these antigen responses differ between different types of clinical phenotypes? So what kind of clinical phenotypes did we take? We took one group as what can be called as true ocular TB based on the Sun classification criteria, which was published last year. And as some of you might know, that these criteria include, for the posterior segment, occlusive retinal vasculitis, serpiginous-like choroiditis, and multifocal choroiditis. In addition to it, we also included intermediate or pan-uveitis that had a positive PCR reaction to for TB DNA. So these are the patients that we called as true ocular TB. Of course, they tested positive for the TB antigen test, the MON2 test or the IGRA test, and they were negative for sarcoid and syphilis. In contrast to this, we classified another group of patients as uveitis of unknown origin, and this we are going to call as UNK in the subsequent slides. And these were the patients who had a positive tuberculin skin test plus minus IGRA, but a negative TB PCR, and these are mainly either intermediate or pan-uveitis, but not matching the Sun TB criteria or any other non-TB diagnosis. That's why they were called as uveitis of unknown origin. The third group that we took was patients who had a negative tuberculin skin test and a negative TB PCR, and again, mostly intermediate or pan-uveitis. So we had a true ocular TB, a uveitis of unknown origin, and non-TB controls. Again, we collected the cells from these patients by pars plana vitrectomy, and we activated those cells by either the TB antigen, which was ESAT6, or with a retina-specific antigen, and now we started using the antigen IRBP. This is what we found. In contrast to our expectations, we found that the cells from the uveitis of unknown origin were more pro-inflammatory than those with ocular tuberculosis. We thought that ocular TB will be producing more cytokines to TB antigen, but we found that the unknown origin cells were producing more cytokines. They were more commonly polyfunctional. Polyfunctional means a single cell producing more than one type of cytokine than the ocular TB samples. Not only that, the polyfunctional cells were also producing more cytokine per cell than the monofunctional cells. Now, this might be a little difficult to pick up in this short span of time, but if you look at the three categories that we have here, the ones in each category, the dots which are on the right side are the polyfunctional cells, whereas the dots which are on the left side are the monofunctional cells. And we have shown that the polyfunctional cells, as you can see here with my pointer, in the case of interferon gamma and in both the OTB and the UNK groups, that they are producing more cytokines than the monofunctional cells. Now, so we find, to summarize, we find that the UNK cells are more often polyfunctional. These polyfunctional cells produce more cytokines than the monofunctional cells. So together we can conclude that the UNK cells have a stronger TB specific and cytokine response than the OTB cells. Now, what is happening to the autoantigen specific responses? There we find that in the case of autoantigen specific responses, they are present in all the three subgroups that we had considered at the beginning of the study. But there was no difference between the cytokine response to IRBP between the different subgroups. And not only that, this cytokine response, when we did a regression analysis, we found that this cytokine response was not affected by the clinical phenotype or the duration of the disease. So to summarize, in the case of ocular tuberculosis, TB antigenic specific intraocular cytokine response can distinguish between the clinical phenotypes of ocular TB in terms of those that are fitting into the CERN criteria and those that are not. Secondly, the autoimmune responses could exist in all forms of uveitis, irrespective of their etiology, with no difference between the clinical phenotypes. And since there is no such difference between different clinical phenotypes, we can presume that this might just be a secondary phenomenon to the primary inflammatory response. And finally, for the future, we need a multi-pronged investigation where we look at more number of parameters, both in terms of the proteins being secreted and also in terms of the kind of gene expression in these cells to really characterize the intraocular immune response. I thank you for your attention and acknowledge the role of my mentors, in this case, Professor John Forrester in particular, who has been very kind in mentoring our project. Also the different funding agencies, in particular the DBT Wellcome Trust India Alliance. I invite all of you to the USI annual meeting that we are holding in Hyderabad between 14th to 16th October this year. Thank you very much.
Thank you, Dr. Basu, for that wonderful talk. And I think it really opens up very much all kinds of new avenues in tubercular uveitis for future. And I would request any comments from the panelists.
Peter, can start with you.
Yeah, look, I mean, they're really intriguing results that don't mean this the way it sounds. I'm even more confused now than I was before. It's sort of a bit counterintuitive, the results that you found. But I guess it tells us that there's clearly an autoimmune response in all these different forms of uveitis, and it may well be one of the major drivers that perpetuates the inflammatory response in the eye. And presumably there are a range of triggers, TB being one of them, and then presumably the T cell profile and cytokine profile changes and it becomes self-perpetuating. That's my 2 cents worth.
I think it's very important what Soumya is showing, because it highlights the role of anti-inflammatory and anti-cytokine therapies, even in the infectious, And I think towards the personalized medicine, these are the kind of the biomarkers which we are going to need in future. And I invite all the panelists to please comment. I know TB is not, your area, but I'm sure there are diseases to which you can just give your thoughts about what do you think, in which direction our future generation should be going with these kind of studies. So we can start with John.
I think Dr. Sunil has raised his hand, and Dr. Sunil is wanting to make a comment.
Yes, Sunil, where is he?
Yes.
Hey, good evening, everyone. Nice to see everybody. It's been great work. I have a question. Have you looked at TB positive controls? So people who are getting vitrectomies for other reasons, detachments, or macular hole, who are TB positive, but don't have any signs of clinical ocular disease?
Yeah, I think that's a great question, and it's very tempting to look at that subgroup. The problem is that these patients do not have enough number of cells in the sample, and when we're talking about flow cytometry, when you do not have at least 25 to 30,000 cells in your sample, it's not possible to do that kind of analysis. You will have to go for other options in those patients.
So that's my next follow-up question is flow is great, but it is limited exactly by what you said, by the need. And I truly believe that there are inflammatory responses that are occurring in many of these patients. And we sort of need to understand what happens even in maybe less aggressive disease or people who are positive but don't manifest disease. So do you have plans for the next step? Is it single cell sequencing for you? Is it proteomic analysis? What's your next step without giving away?
So the next, no, I mean, it's not very easy for us, especially given the situation we are in, but hopefully we should be looking at single cell RNA-seq. That's our dream. So it's not an easy thing to accomplish given the current constraints. But John has a comment after that. I'll just clarify, a little bit about our results, because I can understand they were thoroughly confusing, because I didn't get a chance. I just had 10 minutes with me, so I didn't get a chance to discuss those results.
Let's have a quick comment from all the panelists. And there is a question for you, Soumya, which you can type the answer later on also.
Yeah.
Yes, John, Ahmed, Brian, please.
Yeah, that was a really nice talk and great research. Our group here, which is led by Tui Dewan, we are also trying to kind of characterize the inflammatory profile by different kind of phenotypic responses in the eye, different types of uveitis. And so, one thing to think about is it may not necessarily require that we look on a single cell level, but that's certainly great. I mean, that's getting very granular. It may potentially be just as simple as looking at the whole bulk of tissue and just looking at specific biomarkers or the whole milieu of biomarkers rather in these processes. And so this is where I think RNA sequencing potentially could be helpful, because you can actually look at the whole constellation of genes that are involved and see how different inflammatory responses cluster in terms of the gene profile. And so right now, identifying specific chemokines, cytokines is really, really important. But what if there are other genes that aren't necessarily related to frank cytokine pathways. You know, what if additional genes are involved? We wouldn't know unless we actually look for those. Or the nice thing about RNA sequencing is that you don't even have to know what you're looking for, and you can kind of just see what you get after doing the high throughput sequencing. The other thing to think about is that uveitis may not necessarily be a compartmentalized disease. I mean, it's possible, it's conceivable that even whole peripheral blood may identify a robust signature even from the eye. And it would be interesting to kind of correlate what you're finding in the eye with what you might find in that same patient from the peripheral blood. And we may be finding a robust enough signature despite the uveitis, you know, despite the inflammation being in the eye.
Thank you. Ahmad, any thoughts?
Yes, thank you so much. This is great work, really. I think it underscored the importance of that even infectious uveitis, there's a good autoimmune response going on, and you may need inflammatory treatment or immunosuppressive treatment. So we've seen that in several cases of syphilis patients that after the treatment, and other than the initial inflammation that may happen with the start of treatment, but later on they may have persistent treatment that only responds to immunosuppressive treatment or even intravitreal steroids. So I think that underscores that, and it's so interesting to see how we have a large autoimmune response free with with all types of inflammation.
Yeah, I guess all the infections would probably behave the same way, though Soumya's study is on TV. Brian?
Yeah, very interesting study, Soum. Thank you for sharing with us. I do think that, you know, when we think about classifying uveitis clinically, we think about one, what and how many compartment is it in? And then two, is it infectious or non-infectious? So it's interesting to see that there's significant overlap in a molecular level between infectious and non-infectious uveitis. I'm curious, have you had a chance to look at changes in the cytokine profiles with treatment, either within the eye or, as John mentioned, in the peripheral blood?
Yeah, no, we didn't get a chance because ethically it becomes difficult to collect these samples again from the patients once we have done the primary surgery. That said, it actually highlights one of the difficult difficult parts of such kinds of studies, whether you're doing by flow cytometry or ELISA, or proteomics or RNA sequencing, whichever way you decide to do it. The clinical samples that we get, unlike the animal studies, are so heterogeneous. First of all, the patient might have, by the time the patient comes to you, there could have been some form of treatment already given. Or even if no treatment has been given, the patient might be at different stages of disease. For example, the same retinal vasculitis or serpiginous-like choroiditis could be at different stages of the disease. So how do you compare one stage with another stage? And those of us who have read up enough on the immunology literature will understand how critical this is. But having said that, I would like to clarify one point. So the main highlight of what I discussed was those patients who have uveitis of unknown origin with a positive tuberculin skin test had a stronger pro-inflammatory cytokine response to TB antigens compared to those that we are classifying as ocular TB. Now, when we got this result, we repeated it several times, and we have a fair number with us, 24 patients in each subgroup. We were quite curious, how is it that it's going exactly against our hypothesis? And then we looked at the systemic TB literature, where the blood cytokine responses have been compared between patients that have active TB versus those that have latent TB. And in those cases as well, the patients that have latent TB have stronger cytokine responses to TB antigen, especially the polyfunctional responses to TB antigen, as compared to those that have active TB. In fact, we can safely presume that patients were getting active TB mainly because their host immune response was not good enough to control the infection within the body. And that is one of the ways to explain the kind of results that we got in our study.
You know, we did a study on cytokine profiles from the blood in patients with serpiginous-like choroiditis. We took the samples before in the treatment-naive patient, and then 2 weeks after starting the anti-TB drugs. We were mainly interested to look at the paradoxical worsening, and then at 6 weeks and later. And we realized that the patients who show paradoxical worsening after starting ATT had their TNF going, skyrocket high after 2 weeks of initiation of therapy. So I agree with John, maybe it's not all that compartmentalized, and maybe because blood is easy to get, patients are more open, and, you get the ethical clearances to do it compared to the sample. But very interesting, Soumya. Congratulations for the amazing work as always.
We have a comment from Dr. Peter McCluskey. Please go ahead.
Yeah, I was just going to say, Sum, that the pattern that you described is very similar to that happens with varicella zoster when you get herpes zoster ophthalmicus, that it's the poor immune response or the waning of the immune responses that lets the zoster become clinically evident. And then with vaccination, you improve, the T cell responses, and you then get control again and minimize the relapses of varicella zoster infection.
Thank you. Thanks. Yeah, sorry.
Dr. Soumya, there is a comment by Dr. Jyotirmay Biswas saying that based on your study, would it be justified then to be starting these patients on immunosuppressants? Yeah, again,
these patients are very heterogeneous, like I mentioned earlier. So I think we cannot have general rules for all patients. It will vary from one patient to another. And probably that's the future of medicine that we're looking at, personalized medicine, where we have different protocols for different patients.
I wanted to ask you one question that did you find any kind of a difference between the TB granuloma patients and the other phenotypes of TB uveitis?
Incidentally, we didn't have any patient with choroidal granuloma in our study. So there were occlusive retinal vasculitis, serpiginous, and multifocal choroiditis, but no granuloma. Mainly because these patients have very obvious evidence of tuberculosis, so there is no need to go ahead with the PCR or any vitrectomy is required for these patients. That's why we don't get samples from these patients. But so it would have been very interesting, yeah.
But do you think that an AC tap sample in any way would help?
Yeah, so the number of cells would be very small in AC tap, especially if there is no significant AC inflammation. If just a 0.5 AC reaction is not going to help, unless you have very dense AC reaction, which you can collect and probably do a single cell RNA-seq. I mean, studies have been published from that. But for flow cytometry, I don't think the AC aqueous cells would be enough for flow cytometry.
Right. I'll just take a last comment from Dr. Brian. Please go ahead.
Thanks again. Sum, I just wanted to congratulate you again on your surgical technique for being able to collect samples for flow cytometry. I was wondering if you could comment on that. I know that sometimes even for patients in whom we suspect intraocular lymphoma, it's difficult to get enough cells to perform adequate flow cytometry. So I was wondering if you could comment on your surgical technique on processing and handling the sample.
Right. So the surgical technique involves doing the vitrectomy under low cut rate, 1500, like we do for lymphoma. And also we do the surgery with the infusion fluid on. And this was a major concern for us in the beginning, because most studies will take undiluted samples and then look at the data from undiluted samples. So we started off by taking undiluted samples, doing the vitrectomy under air, keeping the cut rate low. And then once we had completed the vitrectomy under air, we will switch on the infusion and then collect the samples under fluid. And then we got nearly equal amount of cells from both undiluted and diluted samples. And we compared the cytokine responses between the undiluted and diluted samples. And we found that they were very similar. And that was one of the early things that we did in the study. And once we had done that, thereafter, we did our entire vitrectomy with the infusion fluid on. And the only thing that could be a point of concern is that we use a low cut rate of 1500 because we are going to do flow cytometry. And like you do for lymphoma, if the cut rate is higher, the cells get damaged very easily. But so, I mean, we have compared the safety data. We now have like hundreds of such samples. We have compared safety data of these patients, and it just doesn't add in any way to the risk to these patients. Mainly because most of these patients either have a complete PVD or they have an incomplete PVD, where you just need to cut the vitreous attachment to the disc. You rarely need to induce any PVD in any of these patients.
And the cassette fluid works very well for flow cytometry. Like even if you want to have the initial sample under the air, which can go for like PCRs or something that really make a lot of difference to the patient. But the remaining cassette fluid, they just create the centrifuge, aliquate, and it can work for the flow. So
yeah,
I move on, Manisha.
Yeah, so thank you, everyone. I think we've had some excellent discussion and we can endlessly go on this topic. But because of the paucity of time, we'll move on to the case presentations. And I would like to invite the moderators for the next session. That is Dr. Mudit Tyagi, and he's a senior vitreoretina consultant and uveitis consultant at LV Prasad Eye Institute, again, Hyderabad. We also have Dr. Somashila Murthy, who is the head of the cornea, and she's also a very senior uveitis consultant at LV Prasad Eye Institute. We have Dr. Anoop and Dr. Anamika, who are consultant ophthalmologists, again from LVPI Eye Institute, Hyderabad. So over to all of you to moderate the case presentations.
Yeah. We'll start off with the first presentation by Dr. Shashwati Bhushan. Shashwati, will you share your presentation? Shashwati is the first year fellow in uveitis and ocular immunology at the Hyderabad campus of LVPI. Anoop will be moderating this case because he is the one who managed this patient at our Bhubaneswar campus. Shashwati, you start off?
Yes, Doctor. Good evening, everyone.
You're not, yeah.
Audible. Can you speak louder, move closer to the...
Good evening, everyone. Welcome to USI Grand Round. Topic for today's first presentation is little thick macular punctate toxoplasmosis, presented by myself, Dr. Shashwati Bhushan, and moderated by Dr. Anup Kirgaonkar. Objectives for today's presentation are to know punctate inner retinal toxoplasmosis, which is PERT, to differentiate PERT from punctate outer retinal toxoplasmosis, and to know if macular punctate toxoplasmosis present as primary ocular toxoplasmosis. Coming to first case presentation, a 23-year-old male came with chief complaints of gradual diminution of vision in left eye since 3 weeks. He had no other ocular or systemic complaint. His vision in right eye was 20/30, less corrected to 20/20, and left eye was 21/25, improving to 20/30 parts. Anterior segment examination in both eyes were within normal limit. Coming to fundus examination, right eye was unremarkable, whereas left eye showed localized vitreous haze overlying the disc and in the perifoveal area. We see multiple yellow multiple yellow, white lesion with fluffy margin in the foveal and in the perifoveal area. Coming to the zoom image of the left eye, it shows multiple creamy yellow punctate lesion with fluffy margin seen at the foveal and the perifoveal region. OCT scan of left eye with vertical scan passing through the three lesion shows severe grade hyperreflective dots. There were two inner retinal hyperreflective lesion with depth of the larger lesion up to outer plexiform layer. The hyperreflective lesion in the outer nuclear layer extends below with disruption of ELM and ellipsoidal layer with RP elevation with aperture at the apex. There were also hyperreflective dots in choriocapillaries with backshadowing. OCT scan, this is the horizontal scan passing through left eye, which shows hyperreflective dots and hyperreflective membrane over the disc with extension or traction into the vitreous cavity with epiretinal membrane. Fundus fluorescent angiography with lesion nasal to the fovea are isofluorescent in early phase, while have hyperfluorescent in late phase, signifying the port lesion. The other punctate lesion, which is superior and superiotemporal to the fovea, have early hypofluorescence with late staining. Differential diagnosis for this case was white dot syndrome, diffuse unilateral subacute neuroretinitis, atypical ocular toxoplasmosis, multifocal choroiditis, and syphilis. We narrowed down our clinical diagnosis to atypical ocular toxoplasmosis, which is punctate inner retinal and punctate outer retinal toxoplasmosis. Investigation advice were as follows, with toxoplasmosis, IgG and IgM were reactive. Treatment started was tablet trimethoprim with sulfamethoxazole and oral steroid tapered over a month. 2 months after initiation of therapy, we see resolution of punctate lesion around the fovea, and on OCT scan, we see that there was resolution of vitreous hyperreflective dot. The port lesion resolved with minimum retinal thinning and port lesion resolved with minimum disruption of ellipsoidal layer and RP layer. What our understanding till date is, it is an atypical presentation of ocular toxoplasmosis first described by Fredman in 1969. Our findings are, it is seen in eyes with healed or active typical toxoplasmosis. Those are punctate subcentimetric lesion. They are yellowish white creamy lesion, and on OCT, they extend till outer plexiform layer. Port lesion are yellow, white creamy lesion, whereas port lesions are dull, deep yellow, and variably pigmented. On fundus autofluorescent, port lesions have ill-defined, these are ill-defined lesion, whereas port lesions have prominent hyperautofluorescent when in fading stage and malted or hyperautofluorescent in active stage. On OCT scan, the difference between are the port lesion are heterogeneous and hyperreflective lesion extending till outer plexiform layer, whereas port lesion, there is involvement of outer retina, that is ELM, ellipsoidal layer, partially outer nuclear layer, RP, and choriocapillaries. So the fate of these lesions are, there is resolution of lesion with minimum retinal thinning, or they can progress to full thickness retinochoroiditis. So let's see what happened in this case. This patient again came with chief complaints of diminution of vision in left eye with best corrected visual acuity of 20/200. There was an appearance of typical unifocal necrotizing retinochoroiditis, confirming the diagnosis of typical toxoplasmosis retinochoroiditis. Treatment given was oral trimethoprim with sulfamethoxazole with intravitreal clindamycin and oral steroids. There was a resolution of these lesions with minimum retinal thinning. Similar case presentation was with multiple yellow creamy lesion or punctate lesion in the foveal area, where OCT showed hyperreflective lesion in the inner retina extending till outer plexiform layer. The investigation advice were as follows, where toxoplasmosis serology came positive for IgG and IgM. The diagnosis made was macular punctate inner retinal toxoplasmosis, and with treatment, they resolved with minimum retinal thinning. Another case was similar presentation with a yellowish multiple punctate macular lesion, which had similar presentation on OCT, that is hyperreflective lesion extending to outer plexiform, and they responded very well with oral treatment with trimethoprim and sulfamethoxazole with oral steroids. So investigation advice for these, which came positive for toxoplasmosis serology, and the diagnosis was made as macular punctate inner retinal toxoplasmosis. Take clinic message is primary ocular toxoplasmosis can present as macular punctate toxoplasmosis, that is port with port. Presence of combination of inner and outer retinal punctate lesion on OCT is a diagnostic clue for ocular toxoplasmosis, and macular punctate toxoplasmosis can be a precursor to full thickness retinochoroiditis. Questions to the panelists are: what would be the differential diagnosis of port and port lesion if present in isolation, and how do we confirm the diagnosis? And should port and port lesion be treated on the same line as typical toxoplasmosis retinochoroiditis, considering that these lesions may resolve spontaneously? Thank you.
You have to stop sharing because we would like to see the panel. Thank you. Great case.
Dr. Anup, would you like to take up the discussion with the panelists?
Yes. I was this started seeing.
You're not audible.
Not audible.
And now?
No.
You have to come closer, Anup. You're not audible.
Is it okay now?
Yeah, much better.
All right. We started seeing this punctate inner retinal and outer retinal lesions always in association with either a healed or old healed or active toxoplasma lesion. And we also published a series last year on punctate inner retinal toxoplasmosis lesions. But we were thinking, is it possible to have punctate lesions at the macula as a presenting feature or of primary ocular toxoplasmosis? And we went forward, and so far we have these 3 cases wherein the presentation was only punctate lesions, and there were no other either healed or active typical lesions elsewhere in the fundus. So we so far found 2 cases to have IgM positivity, and one of the cases led to typical lesion later, 2 years later. So I had this question to the panel that port lesions with the described OCT features along with the port lesions, if there is a such a presentation, how definite do you think is the diagnosis towards ocular toxoplasmosis?
Thank you, Anup. So that's a wonderful discussion. So let's start with Sunil. You know, Sunil, this part and port reminds me of the medical retina. I said, oh my God, we are coming up with this whole lot in uveitis also.
That's right. I'm always cautious, how we define things. And, for this kind of thing, I guess I asked myself, one, would you ever see intraretinal disease and diagnose toxoplasmosis without any evidence of any outer retinal disease? And do we know for sure that it's truly just intraretinal? Because if you look at a lot of those OCTs, even though there's a definitive intraretinal component, there's also a pretty definitive outer retinal component either right next to that area or in an area that's nearby. So whether that's subretinal fluid or EZ changes or even RPE elevation, it's hard for me to necessarily say that these 2 things are isolated. Is this just a continuum of like outer retinal disease extending into the inner retina? Or is some of this intraretinal changes you're seeing because there are inflammatory cells on top and there's a localized inflammatory reaction? Because I think in some of the OCTs that you showed, there was definitive vitritis over that area. and you can almost see an extension or an eruption into the vitreous. So I guess my question or comment is, do you ever see the inner retinal lesions in isolation? So no surrounding outer retinal changes. And I mean, you have to be very, very harsh with your description, and essentially very careful. Any little outer retinal change is outer retinal change. So I'm curious, have you seen that?
So Ahmad, do you have any opinion about these cases? Do you come across in your practice that are concerned?
Yes, so I think that's a very interesting question. And I agree with Sunil, is usually there's some outer retinal component there. I think if we think of like three groups, okay, the punctate inner retinal toxoplasmosis alone, I think usually we see some outer retinal components. I can recall a case where it looked mainly inner, but I think the diagnosis came that this is an immunocompetent patient with posterior pole retinitis, because the layers are also, you cannot see the layers very well and delineate them. So it's not only inflammation, there's opacification there of the layers. So you know that there's a retinitis as well as vitreous inflammation. So if you add these together, the most common cause would still be toxoplasmosis. And then you would have supportive blood to exclude mainly syphilis and to go with toxoplasmosis. So that's one case it looked very inner. There was some areas of vasculitis nearby, as well as the vitritis, immunocompetent adult, and it's the posterior pole. And then later on, and this patient responded very well to treatment. But usually the ones we see there are more of outer retinal component as well. I find the difficulty, but I did not come across a case like this if there's only port. And my thinking as well, it would be the same line, that would be vitreous inflammation, there would be something going on inner, but I have not seen an isolated port toxoplasma case.
So John, if you come across such a case and you either don't do serology or the serology is negative, and this whole potpourri of white dots. So how comfortable you would be starting anti-toxotherapy based on the imaging and making the diagnosis of PERT and PORT and start specific therapy?
Yeah, I would be, it's rare that we would just treat on imaging alone because, there can certainly be things that are simply missed within a single scan. I think even if we talk about a really, classic case of vitreoretinal lymphoma where it's in the sub-RPE between RPE and Brooks, and, clinically it just looked classic. We still, even in that case, wouldn't initiate treatment based on that because there are even subtypes of lymphoma, T and B cell. So, it's rare that just on imaging alone that we find features that are so pathognomonic that we would initiate treatment on that alone. So, personally, I would still, have done everything that was done here in terms of getting serologies to really kind of confirm suspicions for a specific etiology, rule out other things, including, for example, syphilis, because that can masquerade as anything else. I agree with everybody here in talking about the imaging findings and questioning whether or not the imaging findings, especially on OCT, which is so valuable for us nowadays, really indicates that the primary process is happening within the inner retina. So I think that was really nice that, taking us back to the history of PERT description was from the 60s, if I recall correctly, before we had OCT. And now we have OCT, and we can actually identify exactly where the pathology is happening. But exactly as Sunil was saying, I wonder if, getting, much more dense rasters, the detail scan where the rasters are just really, really close, and identifying where, exactly the full extent of pathology, and actually looking to see if in the choriocapillaris, we might not actually in that same region still see hyperreflective dots. I was going to say something else about that, but I forgot what I was going to say. But anyways, so because on clinical exam alone, that is only telling us part of the picture, but OCT is giving us an additional wealth of information. And I also wonder if there is at least some hyperreflective spots in the choriocapillaris somewhere within that zone. Yeah, thanks.
Thank you. Over to you, Anup. Any other question?
Just I had one thought to put in to the panel. Yeah, I think we did not show all the OCT scans, but it definitely had outer retinal involvement, and below the port lesion there was choroidal thickening as well. So, and second question was almost taken care of when you asked, will you initiate the treatment? That was what my second question was to the panel.
I was going to say something really quick. It'd be interesting to kind of have, a whole bunch of these OCT scans and have people in a masked fashion, not be given the clinical diagnosis, but in a masked fashion, grade these and say, where do you see abnormalities? And, people would mark off, oh yeah, what's in the inner retina? Oh, but then also maybe actually, notice that there are hyperreflective spots in the choriocapillaris, because again, there may be some coloring or some bias, if we're thinking it's PERT, but if you just are given the OCT scans and in a mass fashion, people kind of assess or grade the scans, we might actually find that people are identifying features in other layers of the retina.
Yes, Dr. Sunil, I think you're wanting to make a comment.
Yeah, I think that all the comments are, incredible and valid here. I think one of the questions I think came up with, like, how would you, when you see this, and if it's like a white dot, how do you know what to do? I think, we've become pretty good at identifying, or at least putting this in our differential now, of seeing this vitritis with these punctate lesions and this OCT that looks like, I think it was mentioned, there's a little bit of choroidal lesion, there's definitive outer retinal lesion, and then there's an inner retina. And then you kind of put it together. It's like, well, I have a choroidal inflammation and a full thickness retinitis now. And that probably is suspicious for, toxoplasmosis, especially with the vitritis. So I think putting this in, I hate white dots because I think we just lump things at times and don't really think about really where else everything is. But if you you describe it as you just did, this fits within the, toxos definitely within that differential, and whether it's serology or whether it's presumptive treatment, I think that most of us, would keep this high in our differential and try to prove that it's not before proceeding with anything that's maybe an immune suppressive.
I'll just take a quick comment from all the panelists. There is one question posted by the attendee, that are there any fundus autofluorescence changes described in both cases? And how much of value would you give to serology, especially to IgG antibody in toxoplasma?
Peter, we can talk with you about serology.
Yeah, so with the serology, certainly being IgM positive is really useful. Being IgG negative is also useful. Just being IgG positive alone is not that useful in most cases, but I think at least one of Shashi's cases was IgM positive, and that really makes you feel much more comfortable. And I think it's putting everything together, as we've all been talking about, the clinical picture, the MMI, and the serology are all useful, and the other relevant negatives, of course.
Brian, would you? Your comments on the overall case and the questions Manish asked.
Yeah, I think it's a very interesting case and very helpful to, again, go over the definitions of PERT and PORT, both from the OCT findings as well as the multimodal imaging looking at autofluorescence as well. I do wonder, since we're talking about serologies, certainly the yield of ACPCR for toxoplasma is a bit lower than for viral retinitis. But is there was there an opportunity to check for that in these patients, and is that potentially helpful in addition to looking at serologies for these patients?
Any comment on fundus autofluorescence in these cases?
Sunil?
Yeah, I think if you look in general, right, most toxo will have a combination of hypo, and because I think most toxo lesions to us, at least when we see them, have multiple different types of, lesions from an age standpoint. So I use hyper to help me because I think we all agree, or at least think, we've seen hyper turn into hypo as we treat them. I don't know what hypo in isolation means in these kind of cases because I don't think they switch. So if I see a hypo lesion with a hyper edge or hyper dots, I think that tells me more active, or at least more suspicious. But autofluorescence is in the eye of the beholder sometimes, as is all imaging. It's you take it in, with your other tests. I don't think one by itself is necessary. Maybe OCT. So maybe OCT by itself is fine, but without, I wouldn't use fundus autofluorescence solo. I think with the OCT, I think that would make me a little more suspicious of activity.
So thank you. I think we'll move on to the next case. We've had some great discussion on this particular case. And now I invite Dr. Akshi Sharma, and she'll be presenting on It's Christmas in Retina, SLE retinal vasculitis.
Good evening, everyone. Are my slides visible?
Yes, your slides are visible, but if you could be just a little louder.
Good evening, everyone. Welcome to Uveitis Society of India Grand Round. So we are all in the middle of the year, but doesn't this image take you to the Christmas season? I'm Dr. Akshi Sharma from Uveitis Services, LV Prasad Eye Institute, GMRV campus, Visakhapatnam. And today I'll be discussing a very interesting case. It's Christmas in Retina. And the moderator of this session is going to be Dr. Anamika Patel. So before starting the case, I would like to mention that the fundus photo of this case received an honorary mention in American Academy of Ophthalmology in 2022. So starting with the case, a 26-year-old married female with a 5-year-old daughter presented to retina OPD with chief complaints of diminution of vision in both eyes since 2 days. There was history of fever 4 days back, which was present throughout the day and associated with nausea, vomiting, and headache. There was also a history of hospital admission 2 days back, where she was diagnosed with query viral encephalitis. So when we did the general examination of the patient, we found that the patient had pedal edema and skin rashes. When we did the ocular examination, we found that the visual acuity in the right eye was 20 by 160 and the anterior segment was quiet. But what caught our attention was the fundus image. We found that the media was clear, disc margins were well defined, and there was hemorrhagic retinal vasculitis, confluent retinal vasculitis, small white retinitis-like lesions along blood vessels, retinal whitening at macula, and rod spots along the superotemporal and superonasal aspect of the optic disc. Similarly, when we looked at the left eye of the patient, we found that the visual acuity was 20 by 125. The anterior segment was quiet. And when we looked at the left eye fundus of the patient, we found that the media was clear, disc margins were well defined, and there was superior hemorrhagic retinal vasculitis, confluent retinal vasculitis, small white retinitis-like lesions along blood vessels, and retinal whitening at macula. Further, we did the OCT of the patient and found that in the right eye, there were hyperreflective dots in posterior vitreous. There were hyperreflective lesions involving the inner retina and neurosensory detachment. Similar findings were found in the OCT of the left eye with hyperreflective dots in the posterior vitreous, hyperreflective lesions involving the inner retina, and prominent middle limiting membrane signs. Also, we found that the hyperreflective lesions were present on the optic disc in both the eyes as well. When we did the FFA of the patient, we found that there was blocked fluorescence corresponding to the hemorrhagic retinal vasculitis and peripheral capillary non-perfusion areas in both right as well as the left eye. So now we have a 26-year-old married female with a 5-year-old daughter presenting with pedal edema and skin rashes, and a fundus image showing hemorrhagic retinal vasculitis, confluent retinal vasculitis, small white retinitis-like lesions, and retinal whitening at macula, hyperreflective dots in the posterior vitreous, hyperreflective lesion involving the inner retina, along with neurosensory detachment and prominent middle limiting membrane signs, and blocked fluorescence along with peripheral capillary non-perfusion areas. So what diagnosis should come to our mind? Well, we proceeded with the systemic investigation and found that the ESR and CRP levels were high. ANA by ELISA method was strongly positive, and urine routine and microscopy showed positivity for protein, ketones, and pus cells. So now we have a young female with combined retinal vasculitis, prominent middle limiting membrane sign on OCT, skin rash, feeder edema, and strongly positive PNA. So with all these findings, we made a diagnosis of query SLE-associated combined retinal vasculitis. So we had a differential diagnosis of both high either SLE-associated retinal vasculitis or both high autoimmune retinopathy. We started the patient on tab prednisolone 1 mg per kg OD, along with tab pantoprazole 40 mg OD and tab calcium 500 mg OD. We also did a rheumatologist and dermatologist referral in view of SLE. So we followed up the patient and found that on day 0, the visual acuity was 20 by 160, along with the already described fundus and OCT features. And when we followed up the patient after day 4, we found that there was improvement in the visual acuity to 20 by 100, along with resolution of hemorrhagic retinal vasculitis. And also, as you can see in the OCT image, there is slowly resolution of the posterior of the hyperreflective dots in the posterior vitreous. Similarly, after 1 week, there was improvement in visual acuity along with 20 to 20 by 50, along with resolution of hemorrhagic retinal vasculitis and similar findings in the OCT. And further, after 6 months of follow-up, we found that there was improvement to 20 by 40 visual acuity, along with hemorrhagic retinal vasculitis resolution and settling of disc pallor, along with sclerosis of the vessels. And as we can see in the OCT, there is resolution of the hyperreflective dots in the posterior vitreous, along with the hyperreflective lesion involving the inner retina and the neurosensory detachment. Similarly, on looking at the left eye, we found that the visual acuity was 20 by 125 on day 0, along with the fundus image and the OCT as described earlier. And when we followed up the patient on day 4, we found that the visual acuity had improved to 20 by 50, along with slow resolution of the hemorrhagic retinal vasculitis, along with the high resolution of the hyperreflective dots in the posterior vitreous. Further, on day 7, we found that the visual acuity was 20 by 50 with slow resolution of the vasculitis lesion, along with the resolution of the inner retinal lesion, as well as the posterior hyperreflective dots in the posterior vitreous. Further, after 6 months, we found that the visual acuity had improved to 20 by 25, along with resolution of the hemorrhagic retinal vasculitis and settling of the disc pallor and sclerosis of the vessels, along with the resolution of the hyperreflective dots in the posterior vitreous and the resolution of the hyperreflective lesion in the inner retina and the prominent middle limiting membrane sign. So I would like to conclude my case with the question to the panel: what is the cause of retinitis-like lesions along blood vessels? And were we really dealing with SLE-associated retinal vasculitis or a different pathology such as autoimmune retinopathy? Thank you.
Thank you, Dr. Rakshi, for a very interesting case and beautiful images. I'll start with a quick comment and we'll start with Dr. Sunil.
So I had a case like this, actually 2 cases like this. I'm curious, did you guys go down the road of juvenile dermatomyositis? Because that's what these retinal lesions look like, this kind of sheathing and these multiple punctate lesions in the presentation. That's incredibly dramatic. Juvenile dermatomyositis would be really high in my differential and can have an elevated ANA. So I'm curious, did you do any muscle specific enzymes? Did this patient ever get an MRI, or did they actually end up having a muscle biopsy? Because that is very suspicious for JDM to me.
Thanks, Dr. Sunil. That's a pretty good differential, and see, this was the first ever case that I got to see. And frankly speaking, I've never seen a presentation like this. So this is my first. And but coming to those lesions which she had, by the time we started oral steroids, within a week, we did send the patient to the dermatologist to get a punch biopsy. That was the plan, but everything was resolved. So he was like, maybe when the patients develop this in a future course of time, we can consider the biopsy. That's the reason why we missed out on that, because patient resolved.
Yeah, there are a couple of blood tests you could do. I think it's, and I'm going to show my ignorance, I think it's like TIF1, anti-TIF1. I think there is, NXP2 might be one. And so like there's a couple of ones that you can do that that are helpful. I can send you my case on. I've two exactly like this. They're both JDM with the exact same beautiful, like it's incredibly dramatic presentation with the sheathing and the hemorrhage and the fear of the retina specialist, the uveitis specialist, like, oh my God, what the heck is this? And it's surprising how well these patients, do with immune suppression. My patient in specific, I have 10-year follow-up on her now. And, she's done very, very well. So anyway, that's just my comment. I could be completely wrong, but that's something suspicious to me here.
Sunil, question before we go to John. Did these patients develop capillary non-perfusion over a long-term follow-up that you had?
So we have, we published it recently, and I don't remember where it was, so I apologize, but they had peripheral non-perfusion that stayed stable. So this particular woman that I took care of, never wanted me to treat her with beyond anything immune suppression. And she had some peripheral non-perfusion that never changed. She has a couple little spots of NV. I never lasered it, but I'm 10 years out. I'm treating her, and I have wide field angiography that has never changed on her.
Thank you.
There is a question, there is a suggestion or a comment by Dr. Monsev that the association of hemorrhagic occlusive periphlebitis with multiple superficial retinal infiltrates and prepapillary inflammatory exudates, what he noticed on the optic disc OCT scan, may actually suggest a Behçet's disease. So how many of you would really be thinking of a differential in the form of a Behçet's?
If Monsev says it's Behçet's, we agree. We don't. Monsev Kairala. It would be a differential, of course. But she had other things going on in the skin, and as Sunil said, skin biopsy probably would be able to differentiate, but I will not come in the way of panel.
So we'll go to Soumya, just before you, I'll just take up a quick comment from Dr. John. I think he's been wanting to say something for a while.
Sorry. Thanks so much. That was a great case, by the way. It was certainly, when you look at the first images, it's a very bewildering presentation. I was going to ask Sunil, actually, when you had your case, because ordinarily we don't think of, that's not at the tip of my tongue, juvenile dermatositis, and also the labs to order. I'm assuming your child had skin involvement, and then of course this case had skin involvement, and I guess perhaps a biopsy would help kind of steer you to do the appropriate test. But I was wondering, like your very first case, like what made you think of juvenile dermatomyositis?
Yeah, I wish I could tell you, I picked it up and I knew it. The patient came in with Gotron sign, and then it's the rash over the knuckles and then the rash over the elbows. And she had a diagnosis that was already there, was pregnant, had delivered, wasn't on immune suppression anymore. And in the post-pregnancy space, had this dramatic hyperimmune response. And then my second case, because I learned from the first one, we diagnosed it. So we saw that case and we said, hey, this I think is JDM, sent her in for the workup, and it was positive. And I believe it's a muscle biopsy. I'm not sure it's a skin biopsy. So please don't, again, this is one that I share with my rheumatology colleagues where I say, they think I'm smart sometimes. And I was like, I think it might be JDM, and I'm right 1 out of 50 times. So just say it, if you're right once, they think you're smart forever. So I think it was more of the sheathing that is kind of continuous with the punctate lesions and the dramatic bilateral presentation with the hemorrhage. That is very, very suspicious to me. So that's it. And I'll email the photos to my colleagues here so everyone can take a look.
Over to you, Basu.
Yeah, so the first thing is that, I saw a similar image for the first time when I was with Professor Narsingh Rao in his clinic in Doheny. And, those lesions were right on as if someone had put laser marks on the retinal blood vessels like that. And he sent those blood samples from that patient whose profile I don't remember so much for the autoantibody tests, and all those tests turned out to be positive. And that's how we labeled it as autoimmune retinopathy. In fact, I'm the one who insisted that in this case as well, we put autoimmune retinopathy as a differential. And if I'm not mistaken, maybe Dr. Vishali can correct me here, that Professor Amod Gupta also had seen a similar case where there were lesions overlying the blood vessels, like, somebody had put laser marks on the blood vessels. And even then, probably we thought it was autoimmune retinopathy.
We did think it was autoimmune, but like we were not as lucky as Sunil was, and the patient did not have, much of the systemic disease. So we actually could not find, and as you all know, the lesions just melt away with steroids. And once you start steroids and immunosuppression, you can't really make the diagnosis. So can we have comments from Ahmad and Brian on this case, and Peter, of course?
Yeah, thanks. Thank you so much. This is a great case, Dr. Sharma. And my question was, this patient put on immunosuppression later on, or just systemic steroids taper?
Yeah, thanks for the question, Dr. Ahmed. So yes, post-oral steroids, I'm only observing her, but I have explained the patient the possibility of starting the immunosuppression because she has resolved nicely. There are no neovascularization. Yeah. Of course, the capillary non-perfusion that is there, and the disc pallor which is there. So she's on a close follow-up, but immunosuppression is the next step unless she develops something.
Yeah, I mean, I think my thought of a case like this, we're having vasculitis here, combined arteries and veins. Not many things do that. And I think on the differential is collagen vascular disease, where it comes systemic lupus erythematosus, and maybe others if there are something suggestive, as Sunil said, juvenile dermatomyositis. Again, if something to suggest really in the systemically. The other things we can give combined as well is Behçet and syphilis, and also Behçet and syphilis are very important. So I would keep these as a differential. And I think the the lesions come back would be worth retesting the skin lesions. But I think the main thing is really are we thinking this is infectious or non-infectious, or masquerade, including neoplastic, to try to put it in one of these groups and then treat from there and follow up. So I think what you're doing is great. That's my thought really for this case.
Have you seen these infiltrates in syphilis?
I've not seen that particular infiltrate in syphilis. No, we've not seen that. And maybe the other as well, like group of differential diagnosis is the frost branch angiitis, because some of the lesions do look like frost branch angiitis. Again, a herpes can give you artery and vein involvement, although the case would be is not very typical of herpes. Maybe I would have done an AC tap or to one eye of these to one eyes at presentation, just to exclude that. But I think the constellation of signs and this really what looked like a immunocomplex deposition on the wall goes more with collagen vascular disease.
Thank you.
I'll just take last two comments. One is from Mudit and one is from Dr. Basu. Yes, Mudit.
No, I know this was, first of all, a great case. Just in continuation with the question with Dr. Vishali had raised regarding syphilis. So while we do see miliary lesions and these multiple hyperrefractive lesions in syphilis, those usually are not on the blood vessels like what this case had, and those usually have an associated area of retinitis just associated with them. And so also a little bit more deeper than what these were. These were more superficial as compared to what we would have otherwise seen in syphilis. Though miliary lesions, multiple punctate lesions are very characteristically described in syphilis, but somehow slightly different from this appearance.
So let's have a quick comment from Brian and Peter, our panelists.
Very interesting case and beautiful images. Actually, thank you for sharing them with us. I was wondering if one other potential differential diagnosis to consider. I agree with everything that Dr. Ahmed said, but potentially Irvan. I've seen cases with hemorrhagic occlusive vasculitis that has looked like this and also ended up being an Irvan case and responded well to infliximab and also PRP to the areas of ischemia. I think the one thing that's really impressive is how well the patient responded to just steroids and the excellent return of visual acuity. So congratulations on taking good care of this patient.
Any investigations that you would like to do in this patient other than what were already done?
think Behçet's was also mentioned as something that's on a differential diagnosis. So an HLA-B51 might be helpful as well. And also potentially checking for antiphospholipid antibody syndrome. I think those autoantibody tests might also be helpful.
Dr. Yeah.
Yeah, I think the only thing I would add to the discussion is I've seen a couple of young adults present in an analogous way to this, turned out to have a leukemia. And although I know this case isn't sort of typical, I think that's the other thing I would just keep in the differential, along with Behçet's and herpetic and the other things that we've discussed.
Thank you. Over to Sonia and team for the next case, please.
Yeah, so I'll request Dr. Rashid Tauri from Jhansi to put up her slide. And while she does that, let me also inform that this image, which was just presented, got the honorable mention at the American Academy of Ophthalmology awards, which were announced last week. So that's about it. A brief introduction to Dr. Rashid Tauri. She was a member of our LVPI online uveitis course, and she, did so well during the course. We thought she should be able to present one of her very interesting cases that she's going to talk about now ahead of our own uveitis fellows. So over to you, Rashid.
Thank you so much, sir, for giving me this opportunity. Good evening, everyone. We shall be discussing about serpentine troubles, that is persistent inflammation in tubercular serpiginous like choroiditis. My objectives would be to discuss how the diagnostic tests can mislead us in making an etiological diagnosis of TB, and how atypical a paradoxical worsening can be, especially when it is away from the primary lesion. And how do we rule out other causes of persistent inflammation after ATT for SLC. I have a disclaimer here. Sorry, I don't have a fundus autofluorescence available at my place, though I fully acknowledge how important diagnostic tool it is, especially in SLC cases. My case is of a 50-year-old female who presented with sudden onset progressive drop in right eye vision since 5 to 7 days, had chronic ocular pain for which multiple ophthalmic consultations were sought in the past. Her vision was 636 in the right eye. Fundus showed mild disc edema with peripapillary choroiditis spreading in a serpentine manner towards the fovea, and there were multifocal lesions predominantly along the blood vessels, some of which showed activity at the center of the lesion, and some showed pigmentation at the center of the lesion. Significant to note here is the presence of superinasal skip vasculitis as well. Her left eye was obviously severely scarred. Vision was just hand movements, and there was a mild grade of inflammation in anterior chamber and vitreous. When we looked at her old reports, what she had, in 2016, she had a picture in her left eye. The fundus picture looks very similar to a classic serpiginous choroiditis. Manto that time was 8 mm, and she was treated with corticosteroids. But again, in 2017, she had a further recurrence at the edges, for which she was treated with corticosteroids again. But in 2019, she had a probable episode of anterior scleritis, for which oral NSAIDs and topical corticosteroids were given. Now, looking at all this, we made a diagnosis of bilateral serpiginous-like choroiditis. Left eye was mostly scarred, and did all the investigations, of which all the routine investigations were normal. But to our surprise, both MON2 and TPHA came positive in this patient. However, there was no history of TB contact, but she did mention about genital ulcers around 17 years ago. HRCT thorax showed multiple healed granulomas along with enlarged right paratracheal lymph nodes. So now here we have a practically one-eyed lady with a disc and foveal involvement, and we want to start her on treatment as early as possible. But whether this is tubercular or syphilitic was the diagnosis. We referred to physician where she received 2 doses of ceftriaxone, but in the meanwhile, repeat TPHA report came negative for both patient and husband. So we requested physician for anti-TB therapy, but he refused. Then I myself started the patient on fixed dose anti-TB therapy on 28th April 2022, along with concurrent corticosteroids, 60 milligrams of prednisolone. Now this is at the follow-up visits after 1 week and 2 weeks. What we can notice here, the posterior pole lesion is nicely resolving. All the peripheral lesions have almost scarred. but there was a persistent skip vasculitis in the superonasal quadrant. On further subsequent follow-ups, what we noticed, there was a horizontal spread of these perivascular infiltrates. Vision remained same. Now, what is it that we are dealing with? Is this a paradoxical worsening? Because this is the first thing that comes to our mind in a patient of SLC post-ATT. But the morphology of the lesion is very atypical and they are all away from the primary lesion. So we thought of ruling out non-TB etiologies first, especially syphilis in this case. But a repeat TPHA for the third time and an MRI brain to rule out neurosyphilis was normal. Then we decided to rule out a drug resistance to ATT. But an ideal vitreous biopsy for molecular diagnosis was not available. And also there was only minimal vitritis. So we repeated HRCT thorax again to check the pulmonary disease for worsening, but it showed resolved mediastinal lymphadenopathy. Then we finally labeled this case as a paradoxical worsening only and advised patient intravitreal dexamethasone implant. But due to ongoing corticosteroid therapy, her glycemic control was very difficult. Physician was insisting for a rapid taper of prednisolone and she finally received the implant on June 25th. After the Ozurdex implant, what we noticed, July 2, after 1 week, further horizontal spread of the lesions continued. And they were kind of coalescing together and spreading in a serpentine manner, this one especially towards the fovea. We continued 4-drug ADT this time along with prednisolone, and we noticed that her lesions further, the spread of the lesions further halted, and the vision also improved. But at this time, her SGPT levels were just crossing the upper limit of normal. We also could manage to get an autofluorescence done from an outside clinic outside our city, and it is showing a SLC pattern in the healing stage. So final follow-up visit on July 27, what we have is the vision has improved to 618 from 636 in the right eye, and left eye, surprisingly, it had improved to 6/60. There are no clinically active lesions in any eye, and all the lesions are resolving. But however, this time her SGPT levels are crossing even twice the normal. My questions to the faculty would be, how do you approach positive TPHA results, especially clinically when they are not suspected? And can paradoxical worsening occur away from the primary lesion as well, especially the morphology which these lesions had? And how do you distinguish paradoxical worsening from drug resistance in a patient with SLC? Thank you so much.
Thank you, Rashi. You can unshare the slides. So this was a case managed by her at her private clinic in Jhansi, in Uttar Pradesh. And I thought, I myself had several questions on this patient. So I thought, let's present to the group and understand from the panel.
I think the first question is, could it be syphilis? Ahmad, you see a lot of syphilis. So do you think of clinical presentation where choroid is the predominant site of involvement, would you think of syphilis if TPHA is positive?
Yeah, we had actually a very similar scenario where a patient tested positive for both. So did this patient get an RPR as well? Was RPR done?
Yes, it was done and it was negative.
It was negative, so yeah, and there was any history of treatment of syphilis in the past or no?
No, she just mentioned that she had genital ulcer 17 years ago, for which some local treatment was taken, but it was taken just for 3-4 days.
Right. I mean, I think if the RPR is negative, I would really focus on the TB similar to what you've done. I will keep this at the back of my mind and maybe test again, especially if the patient is like, like high risk for syphilis, but it doesn't seem to be this case in your case. But I think to answer the first question, if the RPR is negative, then I would focus mainly on the TB now as the main differential.
Sunil?
Sorry, I was just unmuting and text and writing things in the chat. So 2 things. I think great job taking care of this. This happens when we do a lot of tests to make sure we're not missing the bad things. we're going to eventually get things that are positive. So I think the way you systematically think through this, check the RPR, does the disease itself make sense? How often do we see syphilis with choroidal involvement only? I mean, all those things just didn't make sense. There isn't a history in it, and it sounds like you were very, you ask your patient and you have a good relationship with your patient. You can ask these things to figure out if they have risk factors. So, sometimes the test will take us one way, and you have to kind of come back and focus on the patient itself. So when I get these scenarios, because we test everyone for syphilis, I recheck because lab error is very common. I check an RPR, and if the RPR is negative, I move on and say I don't try to adjust it anymore, because I just take it as either previous exposure or a false positive. And then I think your group is way better at answering how to handle aggressive tuberculosis, retinitis, and vasculitis in the eye that's paradoxically worsening with treatment. I've learned so much from these conferences from my friends here. I treat my infectious inflammatory disease so much different now than I did years ago, because of clearly the need of some local immune suppression, but it still makes me nervous. And every time I see an Ozurdex in these eyes, I have a few chills, but it clearly works, and it makes sense to me. So I don't think I would tell you that to do anything different. I think you handled it appropriately.
Peter?
Yeah, I agree. I think the one of the things about syphilis, I always remember at a meeting, someone saying that any disease that needs 5 tests to make the diagnosis, the testing isn't that absolutely reliable. And I think that's part of the challenge here. There are other specific tests for syphilis, but I think if the RPR is negative, as everyone said, I would put that not nearly as high in my differential. It looks like TB. Coming from a TB endemic region, it's most likely TB. And I agree with Sunil, putting an Ozurdex into an eye like this always is a bit of a heart-stopping moment, but it clearly works. And the good thing about an Ozurdex is at least you can take it out if things start to go bad. So yeah, I wouldn't manage the case any differently.
John?
Yeah, I agree with everything that has been said. Sometimes these cases, especially when you get a positive treponema specific test, and you don't have something here where a kind of almost a classic presentation of serpiginoid or tuberculous related serpiginoid chorioretinopathy. You have some other type of features of uveitis, and then the test comes back positive for syphilis and you weren't expecting, and then you have to retest. And certainly there are false positives. Actually, even in, I think, the setting of TB, in some cases, some of the treponema specific tests can be positive, but the RPR, I think, is super helpful. And then the retesting, of course. We have here in the US actually occasionally injected Ozurdex for some of our patients with serpiginoid tuberculous-related chorioretinopathy. And again, it was a little scary for us. We had meetings amongst all of us, but the patient was clearly getting worse on 4-drug therapy, and ultimately they did fine.
Brian, do you see such kind of patient in your practice and any other etiologies?
Yeah, a very interesting case, and certainly having Dr. Narsingh Rao as my mentor, certainly I've learned a lot from our colleagues in India and how to treat serpiginous and serpiginous-like choroiditis in the setting of TB, because we do have a fair number of immigrants from TB endemic regions. And so one thing that we noted about this patient was that they did respond well to systemic corticosteroids, but then just didn't tolerate side effects. They were developing diabetes. And so one thing that Dr. Rao and I like to do is, also in addition to considering local corticosteroids, but systemic immunomodulatory therapy. And our ID specialists, I don't know if we found this in India as well, but they tend to prefer using mycophenolate over methotrexate in patients who may have TB-associated inflammatory diseases. And then another comment about the horizontal spread of some of the vasculitis that was a paradoxical reaction to treatment. Those look very reminiscent of like Carolus plaques or Carelius plaques that are we see sort of non-specifically in Toxoplasmosis and other uveitis and retinal vasculitis. So I think that seeing that as a is not surprising in a patient who has a paradoxical reaction to the anti-TB treatment.
Thank you. Well, Rashi, I would just also add my comments. Firstly, great case. You don't have to feel bad for autofluorescence because the case was showing clinically that disease is active, so you clearly did not need autofluorescence to prove it. Now coming to the issues, like all experts agree, this is unlikely to be syphilis. So even if TPH is positive, don't let it kind of take you away from your etiology. It looks like tuberculosis, and the paradoxical worsening can occur much away from the site of the original lesion, and the paradoxical worsening can have a different phenotype compared to what you are already seeing. Now, the problem with these kind of patients, I have 4 of these, like the ones you showed. The problem with this is that they need very high level of corticosteroids to keep them under check. Definitely, you cannot do that with oral steroids because you got to taper them after some point of time. So Ozurdex works very well because you get a very high dose inside. But like Brian said, that Ozurdex you cannot keep on repeating. So you will have to add some immunosuppression in the background because the moment your Ozurdex starts coming down, the steroid levels, it's going to have chances of reactivation somewhere. I have honestly tried anti-TNF injections local in 2 of these patients in addition to Ozurdex, and it works very well, though I had very tough time getting the ethical clearance for intravitreal injection, but it works, but it's not published, so off the record. The question is of, whether it is TB or it is something else. So 2 of my patients actually showed atypical mycobacteria, which is very difficult to manage. And once I discussed with Russell von Gelder that maybe it is some atypical organism which we are missing out, but we had some difficulty in transporting the specimen. But with all of you, Soumya and all, I think it may be a good idea to look for etiologies other than Mycobacterium tuberculosis because these patients do need a very high level of immunosuppression besides ATT. And lastly, 2 times increase in the LFT is not to worry about. It's the 5 times the upper limit when the concern starts. Keep your hepatologist with you. They always have the modifications and they can give you the guided anti-TB treatment. Thank you for the great tips.
Dr. Vishali, I would just take up one more query that she had raised on the last slide is that how would you differentiate between a paradoxical and a multi-drug resistant TB? I mean, that's...
The drug resistance TB is like the patient comes to you, you start the patient on treatment. It's not going to go on fire after 2 weeks of starting the treatment because it will progress like the TB, which is slow growing and which has not responded to your therapy. So once you have given 4 to 6 weeks of therapy and the patient is not responding the way you want, you would think of drug resistance. Paradoxical worsening typically comes within 2 weeks of starting ATT and it really spreads like fire. That is not how the drug resistant TB, because there the phenotype does not change so quickly. So that is, and the timing of it are one of the important considerations.
So I'll take this case, it was continuing till 3 months. The worsening, the lesions kind of spreading was continuing even beyond the 2nd month.
It was responding to steroids and then coming back, wasn't it?
Like few lesions were resolving and few lesions were coming back again.
Try methotrexate also, which is safe. And lastly, like, I might sound crazy, but I have tried interferon therapy also, and intravitreal anti-TNF. Anti-TNF actually works magic here, but I'm not advocating it. So because I'm just,
I would just take one more thing that you said, that you give Ozurdex and sometimes you need to start a simultaneous immunosuppression just to give a cover when the Ozurdex effect starts coming down. So for how long would you like to continue the immunosuppressants in these cases?
Many times, I think one of our things published in Retinal, Basu actually gave comments about how over a period of time the autoinflammation takes out. So many a times you may actually have to continue immunosuppression even after you have stopped ATT. But I don't think there is any kind of clear-cut algorithm for these patients because they are very complex. So you go, along as you see the response to therapy, but it's not a short term.
Dr. Ahmed, you want to comment?
Yeah, just a quick one. I think one thing to consider as well was anti-TB and steroid is that rifampicin is an enzyme inducer. So you might be giving the patient what you think is an adequate dose, but actually it's not an adequate dose. So that's something to consider. And maybe that's again why she was developing that paradoxical response despite being on steroids with some improvement. So that's just something to consider.
That's a valid point, yes. Dr. Basu?
Just a quick one on the immunosuppression part. I mean, Brian mentioned, Dr. Vishali mentioned about adding immunosuppression, but considering that both ATT and the mycophenolate or methotrexate are hepatotoxic, do you think adding two hepatotoxic drugs is an issue, especially in this particular case where we already have a compromised liver enzyme?
I think that hepatologists sort out for us, to be very honest with you. Like we just say that we need to start, and then they figure out, because they move on to levoflox or something, they remove the hepatotoxic from the regimen. So, but if you are pushed to the wall and you need to start, it can be done because within 2 months, your INH rifampicin are the ones which are actually hepatotoxic, which are continued. The other ones are gone in 2 months. So they can replace it with levoflox if you think immunosuppression is important. So they can.
What about intravitreal methotrexate? Any role of that in these cases?
I said that intravitreal methotrexate works very well. Only problem is the short half-life. You have to repeat it frequently, but by and large, methotrexate 2-3 injections and you are sorted. You don't need it too many times. It can be done.
So if we have no further comments, I think we'll move on to the last case of the day. And I'll invite Dr. Ketan. It's not always a sin, post-operative infectious scleritis.
Right, and the case will be moderated by our scleritis hero or Somshila. Yeah.
So hi and greetings everybody. Actually, I'm not able to share my screen. Can you please allow me to share my screen?
You can share.
I think you can try now. I think they have allowed you.
Still not seeing anything.
Vedahi, can we look at this?
Yes, Doctor.
Doctor, click on the share screen button, the green color button.
Yeah. It's not showing anything actually. My PPT is on, but
have you opened?
Yeah.
Just click.
My PPT is open, but I'm not able to see my PPT when I'm putting the share screen symbol.
On top, is it on the basic window? When you click on share screen, there's a basic, advanced.
Yeah.
You'll have to click on basic.
Yeah, on basic I'm there, but the PPT is not showing up.
Doctor, can we share your presentation?
Yeah, sure. Please do that. Yeah.
In
the interest of time, I think you can share this.
Don't worry.
Just tell us when to go next. We will just move
Yeah.
to the next slide.
Sure, sure. Yeah, so hello and greetings everyone. So the next topic for discussion, it's not always since. I'm Ketan, Cornea and Intersegment Fellow at LVP, and Dr. Somshila Murthy will be moderating this presentation. So we'll be discussing about the case of infectious scleritis post-pterygium surgery caused by multi-drug resistant Pseudomonas species. So next, a 59-year-old farmer presented with right eye severe pain, redness, watering, and blurring of vision for 1.5 months. He underwent a pterygium excision surgery locally 2 months back, and about 8 days post-operatively, he started developing his symptoms. So there was no history of trauma or systemic diseases. He had used several topical antibiotics and also topical and oral corticosteroids, but with no relief over the past 1.5 months. So his antibiotics were changed multiple times during this time period. And currently he was using tobramycin and moxifloxacin eye drops along with the tablet prednisolone and doxycycline. So we can just press the next button. Yeah, next to that. So on slit lamp evaluation, the right eye showed diffuse scleral congestion and thinning, which we can see in the central picture, which extended superiorly up to the 12 o'clock. Nasally, there was a large area of avascular thin sclera with visible uveal hue, and the inferior sclera showed conjunctival ulceration and scleral necrosis with thinning and sloughing. So you can click the next so that my arrows will appear. Yeah. Next to that. So this is the inferior sclera, which showing conjunctival ulceration and scleral necrosis. So this thinning was noted to be extending up to the superior temporal area. The rest of the anterior segment and posterior segment was unremarkable except for the nuclear cataract. So the patient was diagnosed provisionally as having right eye diffuse scleritis. Now the question in this was, is it infective or is it inflammatory? So next. So in this case, there was a history of prior pterygium surgery before the onset of symptoms. And like we see in surgically induced necrotizing scleritis, there was a rapid aggressive course and progressive scleral thinning. However, there are multiple sites of abscess in this case with overlying conjunctival ulceration, and the onset was very early between 1 to 2 weeks. So hence we decided to treat on the lines of infection. You can go to the next slide. So we planned the right eye scleral debridement under local anesthesia, which was done on the same day. And the material was inoculated on the slides of grams and 10% potassium hydroxide calcium mount and plated on various culture plates. So the patient was started on empirically treatment with moxifloxacin and cycloplegic eye drops along with oral tablets, ciprofloxacin and pain medications. So next. So the patient was asked to follow up after 5 days. However, he presented in the emergency clinic in 3 days with complaints of sudden worsening of his pain. You can click the next button. So the examination showed proptosis, increased slit edema, and on slit lamp evaluation, there was intense scleral congestion along with pulse pointing in superior temporal and inferior temporal quadrant with anterior chamber inflammatory reaction as well. So the fundus examination was normal and B scan showed no choroidal thickening or T sign. So we could not document his clinical images at this point because the patient was very symptomatic. His extraocular movements were normal. So we hospitalized him in view of preseptal cellulitis. At this time, the culture reports from scleral debridement came and they were now identified as Pseudomonas aeruginosa species. And it was found to be multi-drug resistance with intermediate susceptibility to colistin drug only. So you can press the next one. Yeah, so again, next. So he was started on colistin injection 150 milligram per day in 4 divided doses after taking physician clearance, of course, and topical colistin eye drops 0.19%, 1 drop every 1 hourly, along with the intravenous dexamethasone 8 milligram 3 times a day. Next. So after 3 days, the best corrected visual acuity of patient was improved from counting figure to 20/500, along with significant reduction in his symptoms. So clinically, there was a reduction in congestion and ulceration. The patient was discharged at this point and advised to continue topical colistin eye drops. Also, the patient was given cycloplegics and prednisolone eye drops were started too early. So in between, he was followed. So just previous picture, please. So in between, he was followed and showed progressive improvement with resolution of the scleritis. So this is the picture of 3 months after the complete resolution. The patient underwent cataract surgery at this point, along with the parametric tarsorrhaphy due to his exposure keratopathy following regress proptosis. Next one. So next. So at 1 month post cataract surgery, his vision had improved to 20/125, and there was no scleral activity. in his final visit, we found that he was having a cystoid macular edema post-cataract surgery, and he's currently being treated for the same. Press the next, please. So, as we all know, the gram-negative isolates, especially Pseudomonas species, are the most common organisms responsible for multi-drug resistant infection in India. So, they possess a major challenge in treatment due to their rapid and fulminant course, and ultimately leading to the poor prognosis. Some of these new studies found that there is a difference between the pathogenicity and virulence in multi-drug resistant strains and sensitive strains of the same bacterial species. Hence, it becomes important to study these virulence factors in these particular cases of multi-drug resistance organisms. So go to the next slide, please. So we cultured and genotyped these isolates for virulence genes of Pseudomonas aeruginosa as shown in this image. We found this particular isolate was found to be positive for exo-U gene. You can press the next button, please. Which is associated with high phospholipase activity and more cytotoxicity, but negative for exo-S, which is associated with the invasiveness. So this particular isolate was also positive for elastase, alkaline protease, and might implicate its role in infection as well as immune evasion. And also LADS was positive, which promotes the biofilm formation. So we are currently analyzing these isolates for genes responsible for the drug resistance. So go to the next slide, please. So concluding the case, I would like to present these questions for our panelists. So first question is, what are the differentiating features of infectious scleritis from inflammatory scleritis such as SINS? And my second question is, what was the mechanism of development of the multi-drug resistance in this case? So was it the iatrogenic inoculation from the surgery, or has the resistance developed over a period of time because of the frequent changes in the antibiotics over a short time period? So thank you everyone for patient listening. So I open the discussion, Dr. Sushila Murthy and everyone.
Thank you very much, Ketan. Maybe we can stop share. Yeah. So I think that this case was very important to us. Just like Sunil had said, that when you see a particular case with a particular diagnosis, you've seen a similar one, so you know what's staring at you. So when the patient came back to the emergency clinic 3 days later with that such severe manifestation, so even before we got the microbiology, I knew that we were dealing with a very bad bug, multi-drug resistant bug, and we had already started hospitalizing the patient, and we had already decided to administer colistin because we've had the experience of multi-drug resistant Pseudomonas in corneal ulcers and in other such cases. And it was quite sort of shocking to see that the patient was, literally pan-drug resistant, except for having intermediate sensitivity or susceptibility to colistin. So at least we managed to salvage the patient by treating the patient rapidly. I think we were very lucky there. But the view of the premise that did this bug start off being multi-drug resistant, or because the history was very clear that every 3 days the patient would be started on a new antibiotic because of inadequate response. So did we somehow iatrogenically push this drug into multi-drug resistance? So that is what we're exploring here. So I'd like to open it up to whoever would like to comment. Somebody had their hand raised. Yeah.
Yeah, I'm happy to start. I think that's an extraordinarily good outcome. Well done. It's a really severe case of infective scleritis. Looking at the size of the surgical scar there, did they use mitomycin, do you know, at the original pterygium surgery?
So we don't know. We even tried to contact them. Unfortunately, we don't have any details. And sometimes the doctors would be reluctant to share that as well. Mm-hmm. So we do know the other hospitals the patient went to, and we had the details of the various medications he used, but not about the exact surgical details of the primary surgery. But yeah, it's quite possible.
Yeah. And I think the other striking thing is, if you look at the presentation collage of images, you can see that the sort of creamy yellowish sort of scleral lesions, certainly inferiorly and probably superiorly as well. Yes. And that's why the whole sclera has become so thin in that later photo, that the disease is always so much more extensive than you think it is when you first look at the patient on the slit lamp. And I think that's a valuable clue that it's almost certainly infective. And usually after pterygium surgery, it's not SINS, it's infective. Anyway, that's enough comments from me.
Sunil, you had something to comment.
Oh, I sorry. No, I don't. I think there were other ones. I don't want to take anyone else's time. I don't think it's from topical therapy. I think you said he was a farmer. I don't know what the use of antibiotics are like in your farms in India. In the United States, it's over prevalent. I think we're inducing drug resistance through our food supply. That's my own opinion. So I don't think it's coming from your topical therapy. I don't think it's quick enough. And this is such a win. Great job. Anytime you have infectious scleritis and the patient keeps their eye, that's a win. So I have nothing else to tell you than beyond great job. And you recognized it quickly. And that's why these conferences are so great, because you can see a clinical picture that should make us think for the next patient who's like that.
Emma.
Hi, it's really a fantastic case. And as Peter said, it's a great outcome. I mean, many of these cases end up very badly, unfortunately. I think previous use maybe of topical antibiotics could have been the reason. I don't think it's your use now, because again, it's a short time, but I think previous use, maybe after the 3 therapy, maybe prophylactic therapy for something at the past may have triggered the multi-drug resistance. I just want to highlight something. I think this is still falls under surgically induced scleritis. The question is, it like, okay, under surgically induced scleritis, is it infectious or non-infectious? And that's sometimes hard to tell. In this case, it might be slightly easy because of the florid presentation, the necrosis area, and the pain and the significant redness. So I think that's just an important point. When your diagnosis surgically induced scleritis, by the history, the question is infectious or non-infectious. So that's just the point I would like to highlight.
So a couple of things that were very unusual for this case is that I'm very happy that he had a great outcome. I mean, nobody can be happier than me. But so we did the debridement, or we took sampling from the infected areas that we saw. And that was done in the OR. And then we patched the eye, and then we opened up next day, and we made it from microbiology, it was negative. And then we sent the patient home. And then the patient came back with rapid worsening. So I don't know what happened that tipped the balance. Was it the surgical intervention, which sort of opened up the entire sort of unexposed microbe to the rest of the ocular surface and just worsened it, pushed it across to that stage? And we're very lucky, because if he had the multi-drug resistance all this time, that he didn't earlier manifest with such severe symptoms. So that's one thing that's still bothering me for this case.
Commissioner, there are 2 questions for you. One is that what precautions would you take for doing cataract surgery, and what was the final vision?
In this patient, we didn't take anything additional except that we waited completely for 3 months till there was quiescence and there was no active inflammation. And we did, of course, a clear corneal incision for this patient. And although there was some astigmatism, I didn't implant a toric lens for this patient. And the vision at this point, a month and a half later, is about 21, 25, because the patient now has sort of a cystoid macular edema, so which we are dealing with at this point. And the sclera is so thin, so we can't give him any posterior subtenon or even an intravitreal steroid injection. So again, we have started the patient on oral steroids at this point, because he was already on topical steroids, but he still has cystoid macular edema.
Thank you. And with this, we come to the last part of our webinar for today, where we ask each of you panelists to give a take-home message from the GATE cases that we saw from Team LVP Hyderabad. Great job. And we have a lot of people from different countries. So I would request all of you to please give your final comments, the take home from today's great cases. And we can start with Brian.
Yeah, thank you so much for sharing all of these cases and for inviting all of us and me to participate in the panel. I certainly learned so much. You see the prevalence of different uveitis entities certainly varies by geographic region, and so it's very eye-opening for me to see some of the cases that you see in India. So thank you for sharing everything with us. Certainly, yeah.
Looking forward to see you in Hyderabad.
Yes, thank you. Looking forward to seeing you all in person in October.
John.
Yeah, these were excellent cases. This was a lot of fun. So thank you for allowing me to participate. I've never thought about ocular immunology and inflammation ever at 4:30 in the morning, but so it really tested my thinking capacity. But these were awesome. And again, I was so happy to attend because there's so much learning for me. That was great. I guess one of the take-home messages is always, it comes back, is clinical interpretation is always required. You get these tests, and the tests unfortunately don't always necessarily give you the answers. You really have to look at the patient and how they're responding. And we saw that in some cases, you're getting a positive test, but like you have to actually take a step back and say, is this actually what this patient has? And obviously we know that if you do enough tests, something's going to come back positive, and that doesn't necessarily correlate with what the patient actually has.
Peter.
Yeah, thanks very much. I mean, there's been great cases, terrific discussion, and fabulous images. I think, to me, the take home is that really you've always got to think about infection as, cases, well, 3 of the 4 cases really, showed how difficult it can be sure you've got the right diagnosis and how to manage it and get the best outcome you can. I think there's so many positive things to take home and learn from this, but that's probably the one line for me.
Ahmad.
Vishai, thank you so much for the kind invitation, and thank you so much for the Indian team and fascinating cases, Ree. I would like to echo what Peter said, always think about the infection. I think, try to think of like, big groups, then you chunk down. So infection, masquerade, then inflammation, which one in that group, and then try to put things together. For example, with the case of the port and the PERT, if you put it in context, it's an immunocompetent patient with retinitis, and you have features of this and that makes you think, okay, well, actually, that is most likely toxoplasmosis. And again, I think, always consider syphilis and TB, especially in endemic areas, really as one of the important differential diagnoses. And again, we saw in the Scleritis case, the main thing really is this infectious, non-infectious. I think uveitis management can be difficult sometimes, but the more you see and the more you do and the more you learn, and always make really sure that you can stop and revise the diagnosis, because sometimes that's needed. And thanks again so much. I've learned a lot in this symposium.
And Sunil.
Thanks for the invitation. It's not as early for John and Brian, so I have no excuse for what I say. I would say my advice is always be curious, be suspicious. It's okay to make a mistake. That's the nature of the business. It's okay to ask for help. No one has the right answer all the time. And it's okay to challenge what we previously thought to be true. And that's how we make progress.
Well, with this, we come to the conclusion of another very interesting session, and I would like to thank Team LVP for the great job, and our panelists for waking up so early, and Peter for staying awake so late till night to be a part of it. We would not have the August webinar, which is the last Sunday of the month, because it says basic uveitis course, but it is a meeting of International Uveitis Study Group, which has a whole program. And those of you, we would love to see you guys in person, but otherwise, for those of you who wish to attend virtually, it's available on the IUSG website. So with this, thank you once again, everyone, for your very kind time and great presentations, and look forward to see you the last series of these grand rounds for this session, at least in September, which will be by Narayana Netwale, Bangalore. Thank you very much.
Thank you, everyone.
Thank you, everyone.
Thank you so much.
Have a great day. Bye-bye.
Bye.
Bye, everyone.
Bye, everyone. Thank you.